Welcome to Impact's webinar series. Impact is a clinical trial training platform funded by the Canadian Institutes of Health Research to increase capacity for clinical trials with children and pregnant people in Canada. This webinar was developed for anyone who wants to learn more about clinical trials. You can share it and register online to attend future webinars live. Our free webinars will continue to cover cutting-edge topics in pediatric and perinatal clinical trials. To learn more about future webinars, visit our website www.impacttrials.ca. After the webinar, we invite you to check out other Impact Knowledge Hub resources on dual code. These include courses on a wide variety of introductory and intermediary topics in clinical trials. All Impact courses are created and peer-reviewed by experts from across Canada and provide certificates of completion. We hope you enjoy this free and educational content brought to you by Impact. To learn more about working with us, you can find our contact information online.
Those of you that don't know me, my name is Nancy Butcher. I'm the co-director of Impact. I'd like to welcome you to today's webinar on pilot and feasibility studies, the what, why, and how. So we are sure to learn a lot today from our guest speaker, Dr. Lawrence Magua. He is a research methods consultant and clinical epidemiologist. He is a professor in the Department of Health Research Methods, Evidence, and Impact at McMaster University. And he's also the director of the Research Methodology Center at St. Joseph's Healthcare in Hamilton, where he provides methodological and statistical support for the design, analysis, and reporting of clinical research. Today, Lawrence is going to present to us for about 45 minutes, and then we'll have about 10-15 minutes for general questions from the audience. So feel free to put your questions in the chat or raise your hands and unmute if you'd like to ask your question that way. Following that, if you're an Impact Fellow, please stay on this Zoom link, and we will have a 30-minute closed discussion period afterwards with Lawrence. And if there's any other learners on the call today that are affiliated with any of our partner networks, like Rare Kids Can or Popcorn or the Child and Youth Mental Health Network or others, or if there's former Impact Fellows that want to join in on that discussion period, please just send Chelsea a quick message via Zoom so we can give you access at the end of the session. Something new we're trying today, today's presentation will be provided in English, but if you would like to enable the Zoom live transcription feature, you can do that by using the toolbar at the bottom of your screen and selecting your preferred language. Okay, and before we begin, I'd like to open today's session with a land acknowledgement. On a national level, we encourage all Canadians and visitors to Canada to learn about the Indigenous peoples on the lands of which they live, work, or visit, and become engaged allies together. We as Canadians, in the spirit of truth and reconciliation, respect the self-determination of First Nations, Métis, and Inuit, and their rights and responsibilities in cultures, languages, and the pursuit of wellness. It's now my pleasure to hand things over to Lawrence to begin today's presentation. Welcome, Lawrence. We're so happy to have you today. I think you're on mute, Lawrence.
Thank you, Nancy. It is a pleasure to be here. Today, I'm going to talk about the what, why, and how of pilot and feasibility studies. Before I begin, a few disclosures to mention. I have designed, analyzed, and reported several pilot studies and trials. I am the editor-in-chief of the journal Pilot and Feasibility Studies, and I have also conducted methodological research on pilot studies. So I will be showing you a sprinkling of some of the research that has informed these slides and the way pilot and feasibility studies are conducted. So by way of agenda, we'll look at what pilot and feasibility studies are and what they aren't. We will ask ourselves why we need to do pilot studies. We'll also look into how to design a pilot and feasibility study, and also look at some of the resources available for people interested in pilot and feasibility studies. So first off, what is a pilot study? If you look into stats and epi dictionaries, you would find a number of definitions for pilot and feasibility studies, but essentially it is a small scale test of the methods and procedures to be used on a large scale. And if a pilot demonstrates that the methods or procedures can work, and then you move on to the larger study. Another definition states that it is a small-scale investigation designed to test the feasibility of methods and procedures for later use on a large scale, or to search for possible effects and associations that may be worth following up in a subsequent large study. Um, if you continue searching for definitions, you'll find many additional definitions proposed by different groups. But essentially, the key bits are circle around being able to define the research question properly, test feasibility, test reliability, test validity, ensure that you refine and modify the methodology you're going to use, test the kinds of protocols that will be applied in the study, work on the design, make sure that you're capturing the right variables, and also try out procedures that you want to use in the larger study. So some of the work in this area has been precisely to create a conceptual framework and a definition for pilot and feasibility studies so that it's clear what they are and what they aren't, so that studies can be reported and analyzed in the appropriate way. So the framework that was created by stakeholders interested in this looks like this. So if you have uncertainties about the feasibility of a study, and then you conduct the feasibility study. Among the kinds of feasibility studies you can conduct a randomized pilot study, a non-randomized pilot study, or any other kind of feasibility study, including qualitative and mixed methods design. Your randomized pilot study could be an internal pilot, which means it informs and flows into the main trial. Or it could be an external pilot where it is conducted and you use the pilot study data separately from the main trial that you're trying to conduct. Um, Essentially, a feasibility study asks whether something can be done and should we proceed with it? And if so, how? Whereas the pilot study asks the same question but also has a specific design feature. Bear in mind that a pilot study, by definition, uses the same design as the planned main trial. If the designs are not the same, then it's not a pilot study, it's a feasibility study. So there's a corollary to all of this. All pilot studies are feasibility studies by definition, but not all feasibility studies are pilot studies because you can test feasibility using a wide variety of methodologies which do not match the design that you're going to use in your RCT. I've seen people use crossover designs to get information that will inform a larger trial, even though the larger trial was not intended to be a crossover design, for example. One additional thing to note and terminology which you may find in the literature is proof of concept studies. So pilot studies are not necessarily proof of concept studies. A proof of concept studies generally is designed to determine if a treatment or drug is biologically active or inactive, right? They usually use surrogate markers as endpoint, and they're usually phase one and phase two studies. So proof of concept is very different from pilot studies. And in our journals, we get a lot of people submitting proof of concept studies to pilot study journals, even though the philosophy behind the two is not the same. So why is it important to look at this? Um, the reason why it's important to understand the distinction between pilot and feasibility studies is that there is substantial variation in practice, right? Many studies are not reported consistently, and the terms pilot and feasibility are used interchangeably and inconsistently. And another thing which we noticed based on some of the empirical work we did is that most journals have no editorial policies on pilot studies. So you submit a study and they are unsure whether it's a pilot or a feasibility study. They don't know whether they should publish it or not. They don't know how to process the design, analysis, and reporting features of the pilot study. Ends up either being rejected or being referred to another journal where it may or may not be used. We also have some evidence that when you submit a study to a journal, if the sample size is small, the editors might tell you, call it a pilot study before we publish it. Even though in principle, a study might be small, but that doesn't necessarily make it a pilot study. It may just be an underpowered study. So, the bottom line is, even though there's an increasing number of pilot and feasibility studies being published, the reporting is very suboptimal. There's too much emphasis on hypothesis testing, even though these studies are, for the most part, small and underpowered and unable to appropriately test hypotheses. There are no clear feasibility outcomes or objectives, and they also don't have progression criteria. So if you remember when we spoke about the definitions, progression criteria are required to determine what level of feasibility will permit you to move to a larger study. And then there's also inadequate description of the analytical plans in these studies, and they don't usually mention that the study is designed to inform a future study, which sort of defeats the purpose of it being a feasibility study. Now, in light of all of this, some people have proposed that pilot studies could actually be wasting resources because people are conducting studies that do not inform clinical practice, are too small to show statistical significance, and basically waste participants' time and research dollars. So, given that, the next question we'll ask ourselves is why we actually do need pilot studies. The first thing to note with pilot studies is that pilot and feasibility studies can answer a lot of questions where you have uncertainties. And you can look at process issues. For example, you can look at whether you can actually recruit people into your study or whether people will be retained in your study based on some innovative intervention that you may have. You can also look at the resources required to conduct the study. What are the salaries like? What does the intervention cost? How much do you have to pay for parking and participant honoraria and all of that? You can test those things. You can also look at management issues, right? In terms of potential human and data optimization problems, in terms of workflow. You can also look at scientific issues with pilot studies. So you can look at those levels, you can look at response, you can look at effect estimates and the variance around all of those. So there's a good paper, a tutorial on pilot studies, the what, why, and how, which really covers all of these things. And it's a recommended reading for anybody who is interested in pilot studies. So I'll show you some examples of pilot studies that have addressed some of these issues. In this pilot study, they were interested in looking at the feasibility of procedures and methods, and their outcomes were recruitment rates, retention rates, data completeness rates, and feedback on the intervention, and also the resources required to conduct the main study. In this one, they also looked at recruitment rates, high protocol adherence, the amount of contamination they had, and whether the rate of ventilator-assisted pneumonia was high, right? So these are things which will inform whether a larger study can move forward. You would note that in almost all of these studies, they always look at recruitment rate because recruitment is a key factor. If you can't get people in the study can't go on to begin with, right? And so it's a key thing that you should be sure you can do before moving to a larger study. In this one as well, they looked at recruitment rates, retention rates, participation rates, completion of action plans, the number of feedback reports that came back, and the completeness of the data. In this one, they look at adherence rates or completion rates to the specific risk assessment model that they were using in the study. And in this one, again, they looked at recruitment rates, retention rates, participation rates, completion of action plans, feedback reports, and completeness of data. But one key reason why we should be doing pilot studies is that they save money, right? Research in the UK showed that for studies that they identified to be not feasible and which they didn't move forward to a larger trial, they saved close to 20 million pounds, right? So the pilot studies themselves actually help us save a lot of money because they show us which studies would not succeed, and studies which we should not be investing more money in simply because they cannot be implemented as designed, right? They need major design changes for them to be useful. And there's also evidence suggesting that inadequate assessment of feasibility is the main reason why many trials fail, especially with regards to poor accrual. And that's why you would note that one of the key feasibility outcomes is recruitment and retention rates. You need to be able to get people in your study. So if you are not certain that you can accrue people in your study, and then a pilot study is warranted. Now, how do we design a pilot or feasibility study? There's a lot of text and context and principles that we could go through, but I identified the top six, which I think are key bits, and they're the main deal breakers for our journal, right? If you don't address these things, and then you will either have a desk reject or you will go through several rounds of reviews before your paper is deemed acceptable. It's important to have the right nomenclature. If it's a pilot study, call it a pilot study. If it's a feasibility study, call it a feasibility study, but do not use the terms interchangeably. And whatever you call the study should match the design, analysis, and reporting. You should have progression criteria. Um, you should cover the ethical pieces of the pilot study. You should have an appropriately justified sample size. The analysis should match the intent and purpose of a pilot study, and you should also report appropriately using the right tools. So in terms of nomenclature, there's a lot of literature suggesting that studies are just labeled badly, right? People don't call them pilot studies. And this is problematic because it is hard for them to be indexed appropriately and for them to be found. And if you don't call it a pilot study, and then people might think this is a definitive trial and actually use that information to inform clinical practice. And that is potentially misleading. So make sure you get the nomenclature correct. Now, in terms of progression criteria, this is a very, very critical issue. It is always important to state the criteria for success or feasibility. For example, you're trying to recruit people in a pilot study and you have a feasibility outcome, which is recruitment rate. And you say, you need to tell us what target recruitment rate will make you conclude that a larger trial is feasible. If you can't say that and then the interpretation of your trial becomes subjective and problematic. So when you're writing the protocol for your pilot study, you need to declare upfront that our target is a recruitment rate of 75% or whatever your feasibility outcome is, but you should have a threshold which indicates success. So if you use progression criteria, the traffic light approach is often recommended, and the outcomes could be stop. The main study is not feasible. You haven't met any of your feasibility targets, and you don't think you can move forward with a larger study. Or the outcome could be continue but modify protocol, which means the study would be feasible if you were to make some modifications. For example, you could say you would increase the number of flyers out there to increase your recruitment rate, or you will increase the number of sites to increase your recruitment rate, or do other community outreach activities to ensure that more people learn about your study and participate in the study. Um, Another outcome could be continue without modifications, but monitor closely. So it looks like it's feasible, but there are still some minor lingering concerns about, how things will play out, especially if your feasibility outcomes meet the threshold, but they are just on the cusp of the threshold. They do not surpass it by any large margin. And then in the very, very best scenario, you can continue without modification. Your study is feasible as is, and you can move forward. It is recommended that the progression criteria be based on key primary feasibility outcomes. Given that progression criteria are important, you would note that about 7 years ago, we noted that only about 20% of pilot studies actually reported progression criteria. It is becoming more and more frequent now. We are insisting on having these progression criteria reported, but it's still an uphill battle. We also did some more work looking at external randomized pilot trial publications, and we looked to see if the progression criteria were adequately reported. And we found that only about 56% of them mentioned the progression criteria. So this is an increase from 20% in the protocols, suggesting that people are still trying to get there, but it's taking some time. So ultimately, remember, pre-specified progression criteria are critical for the interpretation and the scientific reliability and validity of your pilot study. The next thing is ethics, right? There are two important questions we ask ourselves when we're looking into the ethics of a pilot study. Is it ethical to conduct a study whose feasibility cannot be guaranteed? And the next question is, what obligation do we have to patients to disclose the feasibility nature of pilot studies? Um, I'd be curious to hear your thoughts about how this should play out, but it turns out there is guidance for this. If you've ever looked at the Tri-Council policy statement, it clearly states that researchers have an ethical responsibility to communicate the purpose and the nature of pilot studies to participants when seeking consent. You must tell them, one, this is a pilot study and it is unlikely that it will change clinical practice. And they should also know that the main outcomes you're looking at are feasibility outcomes. They are not main clinical outcomes. This is critical. And even though this is true and it is specified in TCPS2, we have empirical evidence that among a group of studies reviewed by an ethics board, 83% stated the terms pilot or feasibility in their title, yet only 42% stated the intent to access feasibility in their consent forms, right? And only 20% stated specific feasibility objectives, and only 1.6 stated the criteria for success in the pilot study, right? Suggesting that there are important problems in how people address the ethics in pilot studies. And this is something we could move away from if we are transparent and honest with participants and provide this information in the consent form. The next thing to think about is sample size. I won't go into the details of exactly how to compute a sample size with worked examples, but I'll go over the theory of things. Several papers have been published on how to estimate the sample size for pilot and feasibility studies. And one of the most common approaches is the confidence interval approach, where you specify a threshold of a feasibility outcome with confidence intervals, and then you estimate how many people you need to measure that estimate with a certain level of precision. For example, you could aim for a recruitment rate of 75% and say your confidence 95% confidence interval around that is your margin of error you're willing to accept around 75% is plus or minus 5. So you're willing to accept, you're looking for how many people you need to measure 75% with a precision anywhere between 80 and 70, right? Plus or minus 5. So that's one approach you can use. Folks have published several rules of thumb, some of them based on logic, some of them based on simulation studies, which provide guidance on how to justify a sample size for a pilot study. Some say you need 50% of the total sample size of the main trial, probably too much. Some say 10 patients per group with 40 as a maximum. Some say a minimum of 20 patients in total. Some say 12 patients per group. Some say at least 55. And the paper where this table was pulled from say the pilot study should be at least 9% of the main trial sample size. So actually estimating the sample size for the main study and then using a proportion of that is a very justifiable and very good approach that folks can use as well, especially if you're planning to do an internal pilot study, which rolls into the main study, and then you can estimate the larger sample size, determine a proportion of that 9 to 10%, and then if you meet your feasibility criteria, you continue with enrollment into the larger study. There are other resources out there. This group developed a way of estimating the sample size for pilot studies based on progression criteria, which is innovative and very helpful. They also have a Shiny app, which performs the calculations for you in R, and it's very easy to use, and it also helps calculate sample sizes for pilot studies. There's another paper which specifies how many you need based on the kind of outcomes you have. So 35 per group for a continuous outcome and 60 per group for a binary outcome. Um, there is an even more recent paper that proposes some ways to justify a sample size. But this paper goes back to the confidence interval approach, which I described in the first paper. So the idea is you should have a justification for your sample size in a pilot study. Nobody is asking you for a power calculation, but they're asking for a justification. It turns out sometimes the best justification involves a calculation, but you have several options, including rules of thumbs and statistical software to help you determine what would be the most reasonable sample size. The next piece of advice with regards to sample size is that the sample size should be tied to your primary feasibility outcomes. You shouldn't present a sample size based on a power calculation for a clinical outcome, as that will be considered inappropriate, except if you're calculating a sample size for the clinical outcome for the main trial, and then you're using a proportion of that for the pilot study. Now, if we're happy with our sample size and we have our data, and then we start thinking about the analysis piece of the pilot study. So the first thing you have to do is treat your feasibility outcomes as primary because they are your primary outcomes. So calculate the estimates for the feasibility outcomes. If your primary feasibility outcome is recruitment rate, you need to report your recruitment rate with confidence intervals. You need to report your dropout rates, your data completion rates, participant satisfaction, all of that. Those are the primary outcomes that we are looking for the feasibility studies. And then you need to use benchmarks to interpret them. If your target was 75%, you need to show what you achieved compared to the 75%, right? We do not recommend hypothesis testing, in part because the studies will be generally underpowered for appropriate hypothesis testing, and also because hypothesis testing is potentially misleading. People might read your study and interpret your findings as definite findings with regards to clinical outcomes. We also recommend that clinical outcomes should be treated as secondary and exploratory because you've collected the data, you want to see what the variance looks like, you want to see if your statistical models work. That's fine, you can do that, but it should be clear that these are secondary and exploratory analysis. It's also recommended to report your estimates with confidence intervals and to avoid comparing the two groups because, again, that is not the purpose of the feasibility study. This may be a secondary outcome, but that is not the purpose. With regards to analysis, incidentally, and before anybody asks me the question, qualitative data is a key piece of pilot studies. Now more than ever, more people are including qualitative assessment into their pilot studies, especially when it relates to participant satisfaction, participant perceptions about the intervention, workload for the health workers involved in the trial, and other issues which may affect the implementability of the trial. So we did this paper trying to identify the number of pilot studies that used qualitative data or plan to use qualitative data. And we found the numbers to be very small, right? There are not enough pilot studies taking advantage of the depth of information that can be collected with qualitative methodologies. If you've done your analysis correctly and you start thinking about reporting, There are tools available to report pilot studies. There's a consult extension for pilot and feasibility trials, and the checklist is specifically for pilot RCTs conducted in preparation for a future definitive RCT. Um, there are no restrictions to the terminology used to describe the preparatory trial, and there are no restrictions on the design, but it does not apply to internal pilots, right? The checklist is specific to external pilots. There's a consort checklist. You can use it. It is great, and it covers all the key bits which I have mentioned with regards to design, primary outcomes, progression criteria, analysis, and ethics as well. Now, I am more than happy to share some resources about pilot and feasibility studies with you, but I do not take credit for the existence or preparation of these resources. There is a pilot and feasibility studies collaboration group. We had a meeting this morning, actually, um, and they have for the most part, led the area of pilot and feasibility studies. They created a consort statement, they worked on the framework, and they've done a lot of methodological work to inform the design, analysis, and reporting of pilot studies. And thanks to all the work they put in, the pilot and feasibility studies was launched in 2025. So this year we'll be celebrating our 10th anniversary, a little bit late, but this is the one journal dedicated solely to pilot and feasibility studies, and also where you will get the most appropriate feedback on your pilot and feasibility study. They also have a website which has resources for pilot and feasibility studies, and it is organized by the different aspects of pilot and feasibility studies that you can think of. There are resources for sample size, resources for developing progression criteria, resources for analysis, and so on and so forth. So I highly recommend looking at these resources if you are interested in pilot and feasibility studies. It has references to all the key studies that you should be citing in the design, analysis, and reporting of your pilot study. One other additional resource which will be helpful for all of you is that based on feedback from readers, the conceptual framework, which I mentioned earlier on, has been expanded to clarify how people should go about with designing pilot studies. So here we have a framework which is very simple to follow. So if you've done early feasibility work, you've considered the methods you want to do, and you think, well, based on what I've looked at, there are a few minor issues I'm not sure about. Maybe recruitment rates, maybe participant eligibility criteria, and a few other issues. You can design an internal pilot, right? And the internal pilot will inform whether you should proceed to the main trial or whether it is not possible to proceed to the main trial and you should abandon. Or likewise, if you start off and you have major issues and then you conduct an external pilot with the understanding that the external pilot is finite, you would use the information from the external pilot to design a more robust external main trial, simply because you are aware that there are many issues and the design will likely be different when you collect the information from the external pilot. So this is an interesting framework to have and to bear in mind when you're designing your pilot and feasibility study. So the key messages are that pilot studies provide an excellent opportunity to assess the feasibility of a large full-scale evaluation study. They also enhance the probability of success of the main study because you identify all the kinks and issues beforehand. They are about exploring uncertainties before undertaking the main study, right? And it should have the objectives and outcomes that match the need to explore uncertainties. So you can't say you're exploring uncertainties and at the same time you're trying to determine if one treatment is better than the other. Pilot studies should also be well designed. However, they should be used with caution, especially when you're using the information for pilot studies to determine treatment effects or sample size. Even with sample size, a lot of caution is required because there may be wild changes in the variance of the estimates that you're looking at. And we also think that pilot studies should be scrutinized in the same way as full-scale RCTs because they inform the design of full-scale RCTs. Thanks for listening and happy piloting.
Thank you so much, Lawrence. That was a really excellent overview of pilot and feasibility studies and such a great wealth of resources that you've shared for everyone on the call today. I see we've had a few questions coming in through the chat, so maybe we'll start with those three, and if there's additional questions from there, we'll take those next. I'll read them out loud in case there's folks that don't have access or can't see the chat right now. So our first question is from Lauren Kelly. And she's wondering what happens if your pilot study is launched intending to mimic the confirmatory trial, but what you learn changes the way the main trial will run. So when it's reported, would it still be a pilot study? And would a second pilot study incorporate these changes be needed before proceeding?
That's an excellent question. So this is the difference between an internal pilot and an external pilot. If you need a full redesign of the study, and then based on the traffic light approach, you would be in the first yellow where it says proceed, but with modifications. So it will still be a pilot study, but your main trial would be redesigned based on the information you learned from the pilot study.
Great, thanks. Our next question is from Vikula. Apologies if I didn't pronounce that correctly. They're wondering, how do you handle missing data in a pilot pragmatic RCT with a small sample size? So like an N of 12 in each group. Do we use intention to treat principle? And if so, what are the ways in which missing data can be dealt with?
Thanks for that. So I generally find that if you follow the philosophy of trial design, you start off with a pilot study, which is bare bones. And then if your pilot study works well, you move on to the main clinical trial. And then if the main clinical trial of efficacy works well, then you move on to a clinical trial of effectiveness, right? So that's where you get to the level of pragmatic. So generally speaking, the idea of a pilot pragmatic RCT is somewhat controversial in the sense that pragmatic assumes that everything already works and now you're trying to deploy in the real world, whereas pilot means you're not sure if things are going to work, right? So there's something to be said for the terminal in terms of how you describe the study. But then again, the intention to treat principle is designed for assessing intervention effects, right? You're assessing the outcomes in people as randomized, irrespective of whether they really receive the intervention. So the question of intention to treat doesn't really come up in the pilot study because in the pilot study, the intervention effects are not our main focus, right? If you want to impute missing data and have a complete data set, that's perfectly fine, but that is not the focus of the study. Arguably, the fact that you have missing data which requires imputation suggests concerns with feasibility, right? So that's what I would be looking at to see why we have missing data and how we can redesign the study to mitigate having that much missing data.
Thanks. Great points. Our next question is from Fatima, who says, I have seen studies that are feasibility and effectiveness community trials. So how does one ensure you have elements of both feasibility and effectiveness pilot in the same study?
So in principle, you shouldn't. You can collect effectiveness data for the purpose of understanding whether it's feasible to capture those outcomes, whether the data would be complete, or if you have the tools or if you're capturing the right outcomes. But if the focus is feasibility, let the focus be feasibility. The sample size requirements are different, the design approaches are different, and the analysis approaches are different, right? If you're thinking of a different kind of study, maybe an implementation trial, the feasibility is not about feasibility of design of the trial. It's about feasibility of implementation. So that's an entirely different area of research, right? If you're interested in implementation trials, and then you have the type 1, type 2, and type 3 hybrid implementation trials where you have components of effectiveness and feasibility. But this is not feasibility of trial design. This is feasibility of implementation, right? So you're looking at, for example, whether you have the whatever drug you're doing available in the pharmacy and that it's delivered on time, or if it's a vaccine, you're interested in things like cold chain and so on and so forth. Those are the feasibility issues you're looking for within the context of an implementation trial.
Thanks. I will skip over to Anmol next just to keep going in order, and then we'll go back to the chat. So Anmol, please go ahead.
Thank you for the great presentation. I had a quick question about the analysis plan that we should include in the protocol. I was wondering if you could expand on how specific that should be, because our trial has progression criteria, but we received feedback from someone asking, well, which ones would have to be in the green zone for you to continue on? And we've just stated in our protocol that it'll be based off of critical evaluation and whether we think that
Mm.
modifications are needed. Is that fine, or do you think we should add more about like we want our primary outcome to be in the green or yellow zone, but the others?
So yes and no. Like with feasibility outcomes, it is always helpful if you have a primary feasibility outcome and then you have secondary feasibility outcomes. And then at the very least, your primary feasibility outcome must meet the progression criteria. And then for the others, it is negotiable, right? And then you also need to avoid having too many feasibility outcomes because it makes it challenging to interpret your progression criteria. But that said, what most people do is they have a number of feasibility outcomes, but the progression criteria are built around two or three of those outcomes, or three or four of them, right? And the smart thing to do is to build progression criteria around feasibility outcomes that can be modified, right? If one of your progression criteria is recruitment rate and you don't meet the threshold, there are things you can do to enhance your recruitment rate, right? But or if one of your feasibility outcomes is data completion, and the issue is that participants are not filling out the questionnaire. It might be because the questionnaire is too long, or there may be other things. And if it's a standardized questionnaire, you can make it shorter.
Mm-hmm.
So that wouldn't be an ideal outcome for a progression criteria, because if you don't meet that threshold, you can't say we will move forward, but we will make modifications because you don't have a lot of flexibility to make modifications. And then
Okay.
for some feasibility studies, people who do not use progression criteria state, however, that progression would be conducted by some sort of independent committee or panel who will adjudicate and review all the data to determine whether they will move forward. So if you don't feel comfortable setting progression criteria because there is no empirical evidence on the ideal thresholds for progression criteria, you can say that the outcomes will be adjudicated and a decision to move forward or not will be made based on the discussions of a panel.
Okay, that makes sense. Thank you.
Our next question is from Scott Ramsey, and I think you just touched on this a little bit, Lawrence. So he's wondering about your thoughts on using hybrid effectiveness implementation trials and where you see that they fit in with piloting.
Yeah. So generally, yes, I had actually started replying to that. I have recently started dabbling with implementation trials, and implementation trials happen far along the line in terms of trial design. So you should have done the pilot, you should have done the main studies, you know the intervention works. Now you're looking to see if it works in the real world and how the implementation actually works in terms of other specific implementation outcomes. So for that purpose, you don't really need a pilot. All the information you're collecting, at least most of the information you're collecting is related to feasibility of implementation. You won't call it a pilot, but there will be feasibility components to it. And there are specific frameworks, such as the REAIM framework, which allow you to capture the feasibility of implementation. But where the clarity is needed is the distinction between feasibility of implementation and feasibility of implementation of the trial itself. So issues of recruitment, randomization, data capture, and all of that.
Thanks, Lawrence. It's a really important distinction. So thanks for that great answer. Dennis in the chat is wondering, I missed the distinction between internal and external pilots. How are those terms applied?
Oh, okay, great question. So internal pilots are also called vanguard trials. And the idea of an internal pilot is that the design matches the design of the main study. You start off, you run the study as a pilot. Maybe your pilot sample size is 20 people and your main trial sample size is 100 people. As an internal pilot, when you enroll the first 20, you assess your feasibility outcomes. If you're happy with recruitment, adherence, compliance, data completion, and then you continue the trial, right? And you meet your total sample size of 100 for the main study. So that will be an internal pilot. An external pilot, on the other hand, would be a pilot study designed such that you run your pilot, you capture data on the first 20 people, on the 20 people that you want for the pilot, and then you analyze that data. The study is done. Based on your findings, you may redesign a larger trial and continue with that trial. So the important distinction is that the data from the pilot piece and the main study piece will be considered as two separate studies. Whereas with an internal pilot, both data sets can be merged and analyzed as one.
Great, thank you. The next question is from Busey. And Busey, if you're on the call here, I feel like there may be a question, word missing from your question. If you want to clarify in the chat or just go ahead and ask. Yeah, go ahead.
Sorry. I was wondering if there were any specific considerations that need to be taken if I want to use a waitlist control design for the pilot.
I wouldn't think so. What I would want to know is whether the design for the main study is also going to be a waitlist control. If the design is a waitlist control, and then ideally the pilot should be a waitlist control because you might learn new things about how long people are willing to wait, or whether people are willing to be randomized to a wait list as opposed to intervention now, and that might inform feasibility. Because in other waitlist control studies I've been involved with, when people are randomized to the wait list, they just go to another clinic where they can have whatever treatment is immediately, right? So this might be important information for you to capture that will inform feasibility of your trial.
Thank you.
You're welcome.
Our next question is from Elizabeth. I was considering doing semi-structured interviews about the acceptability of the trial I would like to do, but perhaps I could do a feasibility trial instead. What are your considerations in selecting between these two options?
Okay, so I would take the best of both worlds and do a feasibility trial with an embedded qualitative piece, which would be the semi-structured interviews. But this depends on the kinds of resources you have. If you have no concerns that when you set up your trial, you'll be able to recruit people, randomize them, follow them up, and capture all your data, and then you don't really need a pilot study. You need a feasibility study where you would use your semi-structured interviews to capture information about, whether people are willing to participate in this trial or not. So in one of the first trials I was involved with, I was sending text messages to people living with HIV to improve adherence to HIV medication. And we weren't sure what kind of text messages to send. So we did a qualitative study before that, which served as our assessment of feasibility and asked people, would you be willing to receive a text message? What kind of text message do you want to receive? How often do you want to receive a text message? What content should be in the text message? Would you like the message to come from your doctor or to come from a celebrity? For example, Drake wants you to take your medication, or, we did all of that stuff, and it did help with the design of our study, right? So both options are possible, but you can embed the qualitative piece in the feasibility trial if you do have additional feasibility uncertainties that you want to explore, like recruitment rates, retention, data completion, and whatnot.
Great. We have another question from Lauren, who mentions that the ethical piece is really an interesting discussion. So keen to hear thoughts on communicating the importance of pilot trials to potential participants who may be a bit disheartened to hear or less likely to enroll if their data won't directly contribute to changes in care. Like, any tips around that?
Yeah, so TCPS2 does requirements in terms of how you should communicate this to participants. But I think the key piece in the communication is informing them of the stages in research and letting them know that by contributing to the pilot, they are actually saving time and resources for everybody else down the line, because the pilot may indicate that a larger study is feasible or a larger study might not be feasible. And if you embed a qualitative piece to the pilot study, they may be able to tell you why they think they should move forward with you should move forward with a larger study, or you shouldn't. So I think they are less disheartened when they are not just participants who take part in the study and that's it, as opposed to participants who are asked questions about issues of feasibility. Because people will tell you your questionnaire is too long, right? Or the visits are too frequent, or and those are things which people are happy to be contributing to, right? We told them that the questionnaire was too long, so they made it too short. As opposed to them participating in the study, it doesn't improve clinical practice, and they don't know why or how you came to that conclusion.
Mhm. Great point. And I imagine that could be very rewarding and important for participants to hear the results of what you've learned from pilot trials and the changes that have been made to make the next trial a success and more acceptable to other patients. All right, I think Carmen, you're next if you'd like to go ahead and unmute yourself.
Hi. Within the trial that I'm proposing, I want to look at the safety of home updosing for food immunotherapy. And this we usually do in one way or another within clinical practice, but not like in a structured way. And so what I'm worried about is that I understand now that I need to do a feasibility trial because I don't know how many of the parents are going to intake this, like how good it'll go just only with the remote care monitoring that we have in place, etc. But how am I going to deal with the fact that maybe the kids with the higher, like with the more severe reactions that maybe the parents are not going to want to enroll,
Hmm.
or that so I feel like in a sense it could be biased for leaving out the kids with more severe disease. How do I deal with that
From the pilot study,
from the like a feasibility trial?
okay, that's a valid point, and it is true for all kinds of research, right? The
Yeah.
people who generally participate in research are the people who find themselves in the middle of severity. The people who are too sick can't take part in research, right? The people who are too well are not in the hospital, you will never recruit them. So we sort of get that middle ground and we try to extrapolate to everybody else in the world. But I think you have identified a key feasibility concern. So you would have to work on developing tools to educate and inform the parents on the importance of this study. And you may also need to consider different approaches to consent. For example, in the ICU, deferred consent is allowed because, for the most part, when people are in the ICU, there is no opportunity to get consent, right? But they can be randomized into studies, and then you come to them after the study and say, hey, here's what we're doing. If you're not happy with it, we can take your data out, right? So that might be an approach that you could consider and explore the feasibility of in your trial.
But do you think that anybody will give me a deferred consent to do home versus hospital? I don't know if because I mean like they have perfect. I understand like in an ICU context, but like
Yes. So I may not be understanding the intervention you have described very well, or the context of care in which you're describing it, right? But I think you have already identified one of the key feasibility issues, right? The parents with more severe children with more severe disease will be less likely to enroll in the trial. But they are the ones who actually need to be in the trial the most. So some amount of education and part, patient engagement in the design of the study might be useful in highlighting ways to engage the parents of these patients.
okay, okay. Thank you very much.
You're welcome.
Our next question is from Fatima. How do these trials look in terms of a digital tool that you're testing, instead of a drug?
Thanks, Fatima. Exactly the same. And as I mentioned, one of the first trials I was involved with was in text messaging. There was no drug involved, right? So the design would be exactly the same. You would capture your feasibility outcomes, but with a digital tool, you would still be able to capture enrollment rates, but adherence and compliance might be different because it's a digital tool. So you may have to either download data from apps or things like that. I'm currently designing a trial to use wearables in people living with HIV, and one of the feasibility aspects we're looking at is if people will commit to wearing the device for a period of 10 days continuously, right? And we know they are wearing the device because the data is being recorded. So that recording is one of our feasibility metrics.
Excellent. Okay, we have time for the one last question in the chat, and then we'll wrap up from there and have our closed discussion period with the Impact Fellows. So Vipula is wondering, the behavioral intervention I am evaluating in a pilot pragmatic RCT has been examined in 3 efficacy trials with mixed findings, while non-randomized studies have generally reported positive effects. Despite the mixed evidence, the intervention is widely used in community settings across Ontario. Given this context, our team has chosen to conduct a pilot pragmatic RCT before proceeding to a definitive multi-site RCT. Is this an appropriate and justified approach?
Okay, so the devil is in the details. If I understand what you're saying, it is a pilot because you're trying it in one site, and then if it works in that site, you'll expand it to multiple sites. If that is the case, and then that is a reasonable and justified approach. But again, for most of the pragmatic studies I am involved with, there are no mixed effects. There's no mixed evidence on the efficacy. Everybody knows it works. And then you go to the pragmatic stage to say, well, now that it works in a clinical setting, how do we deploy this in a community setting or in a setting where there are not as many technical resources as in the trials? And I think if you're setting it up as a pilot study, you just need to be clear on what the pilot, the feasibility outcomes are. It could be recruitment, it could be site compliance, it could be staff participation, but make sure that those are clear and that you have clear progression criteria that will inform moving to a multi-site RCT.
Wonderful. Okay, thank you so much, Lawrence, and thank you all for attending and for such great questions and a wonderful discussion period. If you're an Impact Fellow or another trainee, please stay on the Zoom call and we'll resume in just a moment.
Thank you for watching this webinar brought to you by Increasing Capacity for Maternal and Pediatric Clinical Trials. Along with the Knowledge Hub, Impact also offers training awards to transform ideas into evidence-informed clinical trials with mentorship from parents, youth, and academic mentors. Each year, Impact organizes an annual meeting to share ideas and learn about new methods. Applications open in August for our fellowship competition that will start the following year in April. The Impact Summit is an annual meeting bringing together more than 100 leading experts in perinatal and pediatric trials. There are opportunities to sponsor webinars, a specific training award, or sponsor a portion of our yearly summit. These opportunities and other ways to work with Impact are all listed on our website, impacttrials.ca. Finally, we'd like to thank the Canadian Institutes of Health Research and all of our partner organizations which allow us to develop and deliver expert trial content at no cost. Please share our materials with anyone interested in learning more about clinical trials. If you wish to repurpose any of our content or request additional information, please do not hesitate to contact us. You can register for future webinars and learn more about us on our website.